Okay.
Takayasu arthritis. Manohar mute chair. It's a large vessel vasculitis, which is a granulomatous panarthritis. Usually affects age less than 40 years and female to male ratio of 10:1. Presentation is usually non-specific, like patients present with fever, with night sweats and arthralgia, malaise, profound tiredness, and lethargy. They can present upper limb claudication and carotidopathy will be present in 25% of the patients. Most common vessel involved, we all know it is common subclavian artery followed by common carotid artery. And these patients, symptomatic patients, will have stenotic lesions will be seen in Takayasu in 90% of the patients, and aneurysms will be seen in 25% of the patients. Pulmonary artery involvement will be seen in 50% of the patients. Renal artery involvement will be seen in 24 to 60%. So these are the main points. And what are the other manifestations of Takayasu? It can present with aortic valve insufficiency or coronary arthritis. So 74% of these patients will have compromised daily activities, but 15-year survival rate is good. With treatment, it is 95%, more than 95%. So pathogenesis is mainly thickening of the adventitia and adventitial thickening with focal leukocyte accumulation and intimal hyperplasia. So this intimal hyperplasia will lead to the growth factor derived mesenchymal cell proliferation and later into the fibrosis and cause the luminal obstruction. So the main cells involved are dendritic cells, T and B lymphocytes, macrophages. And cause for aneurysm is a local matrix metalloproteases enzymes will be activated in these lesions, and that will cause aneurysm of the aorta or other vessels. So this is the pathogenesis. Diagnosis. So when should we suspect Takayasu arthritis? So these are the red flags for Takayasu arthritis. Takayasu arthritis is mainly clinical diagnosis. There is no definitive investigation to tell it is a Takayasu arthritis. So whenever a patient less than 40 years presents with unexplained acute phase response, like unexplained rise of ESR or CRP, we can suspect. And second point is when patient is having carotidopathy, we have to suspect. And hypertension in less than 40 years hypertension with the discrepant BP between both the arms more than 10 mm and absent or weak pulses in the peripheries or limb claudication, arterial bruit, angina. So less than 40 years, if these features are present, then we should suspect Takayasu arthritis. So it will be variable presentation. Not every patient will have all this. So even constitutional symptoms will be absent in 30 to 50% of the patients. So if any of these symptoms are there, then you have to do investigations like ESR CRP. So ESR CRP elevation will be seen in 3/4 of the patients. More than 75 patients will have ESR CRP elevations. And normochromic normocytic anemia will be there. Thrombocytosis will be there. Hyperalbuminemia, hypergamma-globulinemia will be there. Imaging, we can do ultrasound, cardiac MRI, MRA, MRI angiogram, CT angiogram, PET. In PET CT, we will know the activity by seeing the arterial wall enhancement, edema and thickening can be seen in active disease. Okay, complications. So what are the complications? These disease can cause limb ischemia, aneurysms, pulmonary hypertension, aortic rupture, or aortic valve insufficiency, cardiac ischemia, MI, myocarditis, accelerated atherosclerosis. So these are the manifestation complications of the Takayasu arthritis. In a study, they found that silent MI was present in 27%. So patients will not have any pain, but by doing CT coronary angiogram, they found 27% will have MI changes. Mainly osteal coronaries are involved. So most common is LMC. Osteum LMC is involved in this Takayasu arthritis. LV dysfunction can be due to either disease per se, like myocarditis activity, or it can be due to associated ischemic heart disease or hypertension. So whatever may be the cause, LV dysfunction is seen in 20% of the patients with Takayasu arthritis. And hypertension is usually associated with renal artery stenosis. So management, how do you manage this patient? So first we have to know whether the patient is in active disease or whether the manifestations are due to the sequelae of the already damaged vessels. So for that there are some criteria. I'm just telling the names. NIH criteria is there, and for Indian also 2010 there is a Indian Takayasu ITAS, Indian Takayasu Clinical Activity Score. It is based on this Birmingham Vascular Activity Score. So these scores will be useful to know whether it is a disease activity or it is a sequel of the already disease virus. And to know the quantity or extent of the disease, there is disease extent index DEA top. This index will help in quantifying the extent of the disease. So once you know if the patient is in activity, then we have to main way of treatment is steroids. So we have to start usually prednisolone 1 mg per kg is the dose. But to reduce the toxicity of steroid, ideally now they are advising to give 0.5 mg per kg prednisolone plus other agents like mycophenolate mofetil is used usually, so 2 to 3 grams per day. So along with the MMF and steroid, if we give, then the dose of steroid can be given as 0.5. Otherwise, we have to give 1 mg per kg. So other than steroids, what are the other drugs which are used? So conventional disease modifying anti-rheumatic drugs is there, no? So conventional drugs and biological drugs. So conventional drugs include methotrexate, azathioprine, MMF, cyclophosphamide, leflunomide. So there is no clinical trial to tell the efficacy of these drugs. Only some case series, based on the case series only, they're all used. So usually we use mycophenolate mofetil. Methotrexate and mycophenolate mofetil are well studied, but methotrexate due to its toxicity, so most of us use mycophenolate mofetil. So in
But triple
biological
mycophenolate is costly.
cost, then you can use other drugs.
That's why
Methotrexate
we
only.
use methotrexate in our hospital. Mycophenolate is
Okay.
costly.
వాడుతున్నారు నిత్యం MMF
ఆ,
study.
అదే కానీ యూజువల్ గా ఈపీ వాళ్ళు కూడా సార్కాయిడ్ కి ఇది మైకోఫిన్లెట్ పెట్టరు, మిథోట్రెక్సేట్ పెడతారు.
ఓకే,
నేను
సరే
ఉషా మేడం
ప్రిఫర్
అడిగితే
చేయాలి.
మైకోఫినోలేట్ కాస్ట్లీ ఉంటది అందుకే పెట్టామండి.
ఇప్పుడు మరి చాలా మంది పెడుతుంది మేడం, మేబీ అఫోర్డబుల్
ఓకే.
సో దే టోల్డ్ టు ప్రిఫర్ MMF. ఓకే, దెన్ బయోలాజికల్ డిమార్క్స్ లో tocilizumab is studied, but now they're telling it is better to use other agents than tocilizumab. Biological agents like eptacept is studied, but it is the results are not good. So then they study tocilizumab. One study is good and one study it is not useful. Anti-TNF agents like infliximab, etanercept, adalimumab also are studied and they are found to have clinical benefit. Rituximab is also equivocal benefit. So in biological DMARDs, mainly anti-TNF agents are found to be useful in case series. So this is the coming to vascular interventions. If there is a critical ischemia, then we have to consider for either endovascular or surgical management, like renal dysfunction, refractory hypertension due to renal artery stenosis, or stroke, MI, limb claudication, or bowel ischemia. Then we can consider either intervention, either endovascular or surgical. So in China, one study was done which found there is no difference between either endovascular or surgical. So we can go ahead with endovascular repair. So if the patient of Takayasu develops myocardial infarction, usually they develop non-PVF infarctions. So here CABG they prefer is preferred over the percutaneous intervention. And if these interventions are done during the activity of the disease, the mortality will be very high. So they usually advocate you have to wait till the disease activity is reduced, then only you have to go for the procedures, unless it is very critical disease. Avoid stent unless there is dissection or inability to open the occlusion adequately. So this is the table. So this is the table you can see overview. This is given by ACR. So active Takayasu not on immunosuppressive therapy. If you first time you diagnose a patient with Takayasu arthritis, then you have to give high dose oral glucocorticosteroids along with one non-glucocorticoid, like as we discussed, methotrexate, azathioprine, MMF, TNF inhibitors. So if there is a clinical remission, then after 6 weeks, you can taper the steroids and continue non-glucocorticosteroid agents. If there is no remission, then we have to consider switching the, like if we are using methotrexate, if there is no response, then we can go to other drug like azathioprine or MMF. So like that, we have to change the drugs and see. But steroid, you have to continue. And there is, they say there is no role for pulse therapy. Like IV high dose steroid is not beneficial compared to oral. They advise high dose oral glucocorticosteroids. So other arm is vascular changes on imaging studies. We found some stenosis or something in the imaging. Then if there is associated inflammation along with the stenosis, active disease, then they advise to escalate the immunosuppression. Rather than going for the procedure, they told first you increase the immunosuppression. Instead of escalating immunosuppression, still if there is a progressive ischemia, then we have to consider surgical intervention or any intervention, endovascular. If there is no progressive ischemia, we can continue treatment and monitor. Other side, if there is a progression of existing vascular lesions, so already one stenosis is there and it is progressing now, then again escalate the immunosuppression. If there is no response, go for the surgical intervention. If the symptomatic patients without findings of active disease, continue treatment and monitor. These are the points given by ACR criteria. Here you can see. For any patient requiring surgical vascular intervention, the type and timing of intervention should be collaborative decision between the vascular surgeon and rheumatologist. So they say in patient with Takayasu and persistent limb claudication, without evidence of ongoing active disease, we conditionally recommend against the intervention. So if there is only persistent limb claudication, without any activity, they are advising against the intervention because usually Takayasu patients will develop collateral circulations. So that will bypass the stenosis and the limb ischemia will not occur, only claudication will be there. But if it is persistent limb claudication and it is hampering the activity of the patient, then we can consider for intervention. And the second point we can see here, for patients with the known Takayasu with worsening signs of limb ischemia or other organ ischemia, while even on immunosuppressive therapy, so like we saw in the flowchart, they are advising for escalating the immunosuppressive therapy rather than going for the interventional therapy. So however, some clinical situations here you can see some clinical situations that could warrant immediate surgical intervention include coronary artery involvement or impending or progressive tissue or organ infarction. So if there is a impending tissue or organ infarction, then we have to consider some procedure. And for Takayasu patients with renovascular hypertension or renal artery stenosis, again, they are advocating for medical management over the intervention. So when we have to consider for intervention is again, for hypertension that is refractory, even on optimal medical management, like all antihypertensives we are giving and still BP is not controlled, then despite on optimized immunosuppressive therapy, then we should go for the procedure, like catheter-based interventions. And for patients with Takayasu and stenosis of the cranial or cervical vessel without clinical symptoms, they recommend medical management only, unless there is multiple vessel involvement in the cranial vessels. And this is the last one. So for patients with Takayasu and with worsening signs of limb or organ ischemia, they recommend delaying the surgical intervention until the disease is quiescent or if we perform intervention, the prognosis is good. So when there is worsening signs of limb or organ ischemia, if there is activity, they are telling to escalate and try to decrease the disease activity and then only intervene. So, but if there is a life-threatening or organ-threatening manifestation such as stroke, loss of viability of a limb, or MI, then they are advising for the intervention. Even though we are giving intervention for a patient in active disease, we have to give high-dose glucocorticosteroid in the peri-procedure period if the patient has active disease. Okay. I can get accuracy.
ఎరా స్టంటింగ్ యాక్టివిటీస్ లో పెట్టాలా వద్దని
Unless there is a life-threatening or organ-threatening disease ఉంటే తప్ప ఇప్పుడు అంటున్నారు. కానీ ఇప్పుడు కిడ్నీ పోతుంది అనుకో కంపల్సరీగా చేయాలి. రీనల్ షట్ డౌన్, ఇప్పుడు మన పేషెంట్ కి కంప్లీట్ గా యూరిన్ అవుట్పుట్ లేదు కదా, అప్పుడు ఇంటర్వెన్షన్ చేయాలి.
వీళ్ళలో స్టంటింగ్ వల్ల ఇబ్బంది అంటే
డిసీజ్ యాక్టివిటీలో స్టెంట్ చేస్తే అది యూజువల్గా థ్రాంబస్ ఫామ్ అవుతుంది డ్యూరింగ్ యాక్టివిటీ.
అదొకటి వీళ్ళది టెన్సైల్ స్ట్రెంత్ ఆఫ్ ద వెజల్ పోతుంది అంటది బికాస్ ఆఫ్ ద మిడిల్ ఫైబ్రోసిస్ స్టంట్ అండర్ ఎక్స్పెండ్ అయ్యే ఛాన్సెస్ చాలా ఎక్కువ ఉంటాయి.
నన్ను హోస్ట్ చేయండి.
నువ్వు హోస్టే కదరా మన బ్యాచ్.
చేశారా?
పోస్ట్ అయిపోయింది,
వచ్చింది పిలిబం వచ్చింది ఇప్పుడే.
అయ్యావా కదరా మళ్ళీ ఏమంటావేంటి?
అవతార్ ట్రయల్ స్టార్ట్ చేస్తాం. సో 1 or
3 పార్ట్
అవతార్. So the main goal of this trial is to test whether asymptomatic severe AS patients with normal LVEF can get benefited with early intervention versus conservative approach. So according to guidelines, if a patient is having symptoms and severe AS, that is a class 1 indication for surgery. If a patient is asymptomatic, still if the EF is less than 50%, that is also an indication for surgery. But if a patient is an asymptomatic, EF is normal, then there is no indication for surgery unless there are some specific high risk groups like very severe AS where the jet velocity is more than 5.5 or more than 60 mean pressure, or abnormal exercise stress test, or increase in the NT-proBNP more than 3 times the normal value on 3 consecutive, more than 2 or 3 consecutive readings. And also if the EF is persistently decreasing on 3 consecutive echocardiograms less than 60. So these are soft indications for considering the surgery. So this trial is done in asymptomatic patients who are having normal LVEF. So this is an international trial and it is an RCT. So previously there were many observational studies, but there were no RCTs. So recently they are doing RCTs in this subgroup. There are already ongoing TAVI trials, and also this is the surgical aortic valve replacement trial. Early TAVI is TAVI trial for similar subgroup. So this is an international prospective randomized control trial. So I'll tell the results and conclusions afterwards. So what are the clinical implications? The positive composite endpoint the tested were this trial tested was all-cause death, acute MI, stroke, or unplanned hospitalization for heart failure. So this was there in 15% in surgical group versus 34% in the conservative group. This was the result of the trial. So usually about quarter of the patients with severe AS referred to the hospital does not have symptoms. So they are asymptomatic. So current guidelines, they recommend only watchful waiting. That is, we have to wait for the patient to develop symptoms, or when the EF starts dropping, then there comes the indication for surgery. Till then, we have to wait and watch. So the decision to operate on asymptomatic patient, it remains subjective and supported mainly by observational studies with low level of evidence. Only one randomized trial performed at 4 medical centers within one country appears to support early surgery in asymptomatic patients with severe critical AS, that is velocity more than 5.5 meter per second or mean more than 60. However, true absence of symptoms was not well documented because no regular exercise testing was performed, that is recovery trial. So this trial, Avatar trial, it is done in 9 centers. This is basically done across the Europe. The study population is inclusion criteria is more than 18 years, presenting with severe AS according to the standard echo guidelines. So patients inclusion and exclusion criteria. So they were very stringent in inclusion and exclusion because this is the early trials which show non-inferiority. So they don't want to mess up the trial. So they were very stringent about the inclusion criteria. So the men and women who are aged more than 18 years were taken, and he or she should fulfill the criteria for severe AS according to the echo. And they should not have any reported symptoms. And also the surgical risk for aortic valve replacement, that is the STS score, should be less than 8%. So this is basically the low risk population. And exclusion criteria, they have taken, they have excluded pregnant people. And also if to rule out subclinical symptoms, what they have done is they have done TMT for all the asymptomatic patients. Those who got TMT positive, they were excluded. So they thought that these TMT positive patients either symptom onset during TMT or abnormal hemodynamic response to TMT, those were excluded. So if a patient develops angina, syncope, or dizziness during exercise treadmill, or if a decrease in systolic BP more than 20 mmHg, or if there is a malignant arrhythmia like VT or VF during excess testing, they were excluded. EF less than 50% were excluded, and a very severe AS was excluded. If a patient is having associated other valvular disease like mitral stenosis or regurgitation, were excluded. Recent MI excluded. If a patient is having simultaneous bicuspid valve and aortic valve aortic root dilatation, they who requiring Bentall, they were also excluded. Patient who are requiring who had undergone previous bypass were excluded. And renal failure, if COPD, significant pulmonary hypertension, significant systemic hypertension, uncontrolled diabetes, everybody was excluded. So they have done treadmill versus ergo bicycle test, and they have reported positive if a patient developed severe chest pain, dizziness, syncope, or ST elevation or depression more than 2 mm in the presence of LVH, because AS patients will have LVH. And if there is a hypertensive response to excess TMT, that is more than 240 by 120 mmHg, or drop in the blood pressure, they were excluded. So this was the inclusion and the exclusion criteria. So 14 patients had a positive exercise test. Out of them, 7 patients had symptoms. 2 patients had like symptoms like chest pain. 2 patients had dyspnea. 1 has giddiness, and 4 did not had increase in heart rate. Target heart rate was not achieved. So trial procedure. This they are randomly assigned to early surgery versus conservative by web-based interactive response system. Patients assigned to the early surgery group have undergone surgery as early as 8 weeks. I mean, less than 2 months after randomization. So they have taken 197 patients. 40 were excluded after the exclusion and inclusion criteria. So they got a total of 150 patients. They have divided into half for conservative and half for surgery. Out of them, 6 patients who were awaiting surgery did not receive intervention because of various other reasons. So finally, we got around 79 versus 72. So, and also there was some crossover. Patients in the conservative group, if they developed AS symptoms or if they developed a drop in the EF, or if the peak aortic velocity is increasing more than 0.3 meter per second per year, then they were referred for surgery. That was a crossover. So what are the trial endpoints? The composite endpoint, that is the primary endpoint, is a mixture of all-cause mortality or MACE. That MACE includes MI, stroke, and unplanned hospitalization. There were various secondary endpoints, that is like safety endpoint in the form of post-operative mortality in operated patients, and repeat aortic valve surgery in operated patients, and repeated MACEs. That is, all those were included in the first. They have also made it a secondary endpoint, and also major bleedings, because some patients had mechanical valves, almost 50%. So major bleeding with the BARC system was assessed, and thromboembolic complications. These are all prosthetic valve complications, and time to death and time to first hospitalization. So this is basically event-driven trial. That is, they have assessed that certain amounts of patients have undergone surgery. So within this much of time, they have expected these events would happen. So after that events happened, then they thought of stopping the trial. So the target was 35 events. That is called event-driven trial. The primary analysis was performed as intention to treat analysis for all included patients who were randomized. So what are the results? So average age was 67, and half of 60% were men, and the STS score was less. And also the surgical risk for mortality with the operation is 1.7. That is, they are very low risk people. And the cause of AS was degenerative valvular disease in 84%, bicuspid valve in 14%, and rheumatic valve in 1%. So what have they done? Replacement is 53% of the patients received mechanical valve. 47% have received నిమిషం ఆగండి, అసలు రికార్డ్ చేస్తున్నాను నేను. ఓకే, సరే, రికార్డ్ అవ్వట్లేదు అనుకుంటా. అసలు రికార్డ్ అనే ఆప్షన్ రావట్లేదు నాకు. సరే, ఓకే. సో 50%, 53% mechanical valve, 47% bioprosthetic valve, and the median time from randomization to surgery is less than 2 months. And also there was a crossover from conservative arm, that is some 25 patients had surgery. In that 40% had mechanical valve. So this is the age. Age was roughly around 68 years. And days from randomization to surgery is 55. And from the crossover group, that is from the conservative group, it was 400. Okay. So all other variables are almost similar in both groups. They are not statistically significant difference. And the indications for AVR in crossover group was 60% had AS related symptoms, 16% had AS progression, EF dropped in 4%, and combination of factors in 20%. So they were followed up for 3 years almost, 32 months, and 28 months in the early surgery group and 35 months in the conservative group. So they have targeted 35 events, no? So the total events were 39 events. That is 16% in the early surgery, 32% in the conservative treatment. So we can see there is a significant difference between the primary endpoint. So this is the Kaplan-Meier curve for the primary composite endpoint. This was significantly different if a patient has undergone early surgery versus conservative management. 15% versus 30%. This is the primary endpoint difference. Whereas if we take the secondary endpoints, those were not significantly different between the groups. But combined, the primary endpoint was different. These are the secondary endpoints. This does not have any significant p-value. So this trial has shown that we should consider early surgery in severe AS asymptomatic patients. Discussion. So if a patient is having even in spite of being asymptomatic, they can have structural and functional impairment of the LV with potential adverse clinical effects, including the development of heart failure with preserved or reduced EF. So observational data also challenged a relatively benign course. So it is really not benign as we thought. By reporting a mortality rate reaching 10% at 1 year and increased MACE incidence at midterm. So there was a recovery trial. So recovery trial compared early surgery versus conservative care for asymptomatic AS, provided the first direct support for early surgery in highly selective subset of asymptomatic patients with severe AS. But there were some differences between the recovery trial and this avatar trial. So this trial, in contrast to the recovery trial, who presented with more critical AS with mainly bicuspid aortic valves, they have taken recovery trial. And their estimate in those asymptomatic patients, if we do a TMT, around 20 to 30% people will be excluded because they will be having positive. So avatar trial has excluded those patients, whereas recovery trial has not done any TMT. So there were some amount of subclinically symptomatic patients included in the recovery trial. The inclusion trial were consistent with the lower risk population in avatar trial, whereas recovery trial has taken some high risk patients also. But the primary endpoint was significantly different, whereas the secondary endpoints, they were also having some amount of different, but they were not statistically significant. So overall cardiac death did not significantly differ between the randomized group, but when combined with all-cause mortality and MACE, it was significant. The negative points are there is no core laboratory of echocardiography and stress testing. And also it was very challenging to take a consent from an asymptomatic patient to undergo a open heart surgery in the absence of guideline recommendations. So they advocate that once the AS becomes significant, early valve replacement improves the patient outcomes regardless of the symptom status. Completed.
Event driven trial అంటే 35 ఈవెంట్స్ వచ్చేస్తే ఆపిస్తారా?
ఆపేస్తారు. డ్యూరేషన్ తో సంబంధం లేదు. ఇప్పుడు సర్జరీ అయిన తర్వాత ఎన్ని రోజులు ఫాలో అప్ చేయాలనేది కొంతమంది డ్యూరేషన్ ఫిక్స్ చేసుకుంటారు కదా, 5 years అట్లా. వీళ్ళు అట్లా కాదు, 35 ఈవెంట్స్ రాగానే వీళ్ళు ఆపేస్తారు.
అది ఎవరికి తొందరగా వచ్చిందని చూస్తున్నారా?
బేసికలీ ఈవెంట్ ట్రయల్ అంటే వాళ్ళు ఎక్స్పెక్ట్ చేశారు ఇన్ని ఇయర్స్ పడుతుందని, అని ఇది బేసికల్ గా 5 years చేశారు, 2015 to 2020 వాళ్ళు ఎస్టిమేట్ చేసుకుని 2020 వరకు.
ఈవెంట్స్ అంటే అన్ని కలిపా? డెత్, హార్ట్ ఫెయిల్యూర్, ఏఎంఐ, స్ట్రోక్
అన్ని 2015 to 2020 అనుకున్నారు వాళ్ళు, కానీ 2021 వరకు ప్రొలాంగ్ అయింది ఈవెంట్స్ వల్ల. అదొకటి, ఇంకా కోవిడ్ కూడా వీళ్ళ స్టడీని ఎఫెక్ట్ చేసిందంట.
ఇప్పుడు ఎంత ఈవెంట్?
15% ఏమో ఎర్లీ సర్జికల్ గ్రూప్, 30% ఏమో కన్జర్వేటివ్ గ్రూప్.
వీళ్ళు ముందు టార్గెట్ ఏం పెట్టుకున్నారు ఈవెంట్?
వీళ్ళు 35 ఈవెంట్స్ పెట్టుకున్నారు.
ఆ టేబుల్లో
అదే 35 ఈవెంట్స్, 39
నెంబర్ ఆఫ్ మేస్ అని ఇచ్చాడు చూడు.
35
కన్జర్వేటివ్ గ్రూప్ లో 33 ఉన్నాయి కదా.
ఎక్కడ?
టేబుల్ 4 టేబుల్ 4.
టేబుల్ 4. ఇదే కదా నెంబర్ ఆఫ్
నెంబర్
ఈవెంట్స్.
ఆఫ్ మేస్ అని, నెంబర్ ఆఫ్ మేసెస్ అని ఒక టేబుల్ ఉందా?
ఇదా? ఇది కాదు. ఎక్కడ ఉంది? ఇదే ఇదే
ఏమిచ్చాడు?
ఇక్కడ ఉంది టోటల్ 33 ఈవెంట్స్ ఇన్ కన్జర్వేటివ్, 16 ఈవెంట్స్ ఇన్ ఎర్లీ సర్జరీ.
33 రావగానే ఆపేశారా?
ఆపేశారు.
ఈ టేబుల్ ఇంపార్టెంట్ అండి.
క్లోజ్ చేద్దామా?
రేపు ఇది చెప్తారు.
ఓకే.
మన ముగ్గురే ఉన్నాం, ఇంకెవరు లేరా?
లేదు, మేడం ఉన్నారు, విజయ మేడం ఉన్నారు.
ఓకే ఓకే.